I'm a fourth-year medical student at Rutgers Robert Wood Johnson, and I'm going to be presenting on Scheuermann's kyphosis. So just briefly, I'm going to be talking about a patient with a Scheuermann's kyphosis, followed by some epidemiology and the natural history of the disease. I'm going to go over how Scheuermann's kyphosis presents clinically and radiographically, followed by some treatment options, both non-surgical and surgical for Scheuermann's kyphosis. So DN is a 16-year-old male with a history of transposition of the great vessels, status post cardiac correction back in infancy, who's been seen at the office for multiple years. Today, he's presenting with progressive kyphoscoliosis that has been non-responsive to bracing, and he's presenting with increased thoracolumbar pain, as well as concerns about his aesthetic appearance due to the kyphosis. Just as a quick overview of what he's seen in the office, back in 2015, when the patient was 9 years old, he was started on bracing when his kyphosis was seen to increase from 70 to 77 degrees. After many years in 2021, because of reaching skeletal maturity, patient noncompliance, as well as not having any back pain or aesthetic concerns that the patient was reporting, bracing was stopped. However, the patient did continue to proceed with Schrock physical therapy, which is physical therapy specific for scoliosis and kyphosis, which focuses on elongation, stabilization, and derotation. Less than a year later, however, the patient presented back to the office with increasing thoracolumbar back pain and unhappiness with his clinical appearance because of the kyphosis. Because of his progressive curve to about 84 degrees, which I'll show on the next slide, as well as some of these findings, surgical options were discussed with the patient and the family. So here you can see a standing and hyperextension lateral radiograph of our patient. The standing radiograph demonstrates about an 84-degree thoracic kyphosis, and the hyperextension lateral shows minimal correction to about 66 degrees in the thoracic kyphosis curve. There are other findings that are typically found with Scheuermann's kyphosis, such as anterior wedging and hyperlordosis, and I'll talk about these a little bit later. So after discussion with the patient and the family, surgical procedure was agreed to be performed. So on August 3rd, the patient underwent a T2 to L3 posterior spinal fusion with pedicle screw fixation, as well as a T6 to T10 ponte osteotomy. On the right, you can see a postoperative film of the patient while he was lying down, showing a correction of the thoracic kyphosis to about 63 degrees. This is around the amount of kyphosis seen in the patient's hyperextension lateral, which is about what the attending physician was attempting to achieve. Just a brief postoperative course for this patient. It was fairly uneventful, just some transient urinary retention that was treated with intermittent catheterization. This spontaneously resolved on post-op day 4, and then on post-op day 5 with adequate pain control, spontaneous voiding and passing gas, as well as tolerating food and fluids. The patient was discharged home. So just briefly a little bit about Scheuermann's kyphosis now. In a typical person, normal thoracic kyphosis can range from 20 to about 45 or 50 degrees. However, in Scheuermann's kyphosis, this thoracic curve can be more pronounced. There are two forms of Scheuermann's kyphosis. The most common is a thoracic curve that typically spans from T1 to L1 with an apex around T6 to T8. However, the more severe form is kyphosis found in the thoracolumbar or lumbar only region. And this has a worse prognosis, is much more likely to progress, more associated with back pain, and can have more severe end plate deformities that I'll also discuss later. So our patient had the thoracic only form of this Scheuermann's kyphosis. There's many theories as to what causes Scheuermann's kyphosis, ranging from childhood osteoporosis to some genetic abnormalities. But the most commonly accepted theory is some abnormal enchondral ossification of the vertebral end plates and some bone defects. So essentially, with the natural kyphosis in a person, the compressive forces in the anterior aspect of the vertebral body, coupled with the tension forces on the posterior aspect, will cause some of that anterior wedging and cause progressive kyphosis in the region. Typically, this occurs between 10 to 12 years old and is found in males at a 2-to-1 to 7-to-1 ratio. So these two natural history studies by Murray et al. And Garrido et al. Kind of detail some of the natural progression of Scheuermann's kyphosis in a patient. So if they're not addressed, the curve can continue to progress by about 0.5 degrees per year, typically to about 70 to 75 degrees as when it stabilizes. Cardiopulmonary deficits are not typically seen in these patients until the curves exceed about 100 degrees. Patients with Scheuermann's kyphosis compared to controls will endorse increased back pain and will typically take jobs with limited activity. However, the degree of the thoracic kyphosis is not directly correlated with the amount of back pain that they have or their quality of life. The only thing that correlates with the amount of kyphosis is the patient's self-image and self-confidence. So a patient that presents with Scheuermann's kyphosis will typically be a young male, growing male, that will have a pronounced thoracic kyphosis. On asking the patient to flex, they will have a sharper angulation and more pronounced kyphosis as seen in this picture to the right. On asking the patient to extend, it is a relatively rigid kyphosis. So as seen in our patient, even on hyperextension lateral, it will cause a minimal change in the actual thoracic kyphosis. This is as opposed to postural kyphosis, which will correct to a much more significant degree. Radiographically, the characteristic finding in Scheuermann's kyphosis is 5 degrees of anterior wedging in at least 3 consecutive vertebral bodies. This is caused by that compressive and tension forces that I described earlier. You can see in our patient, at least 5 vertebral bodies have at least 10 degrees of anterior wedging, which meets this criteria. There can also be end plate defects because of the abnormal end chondral ossification seen in this disease. So you can see disc narrowing, end plate irregularities, and in more severe cases, you can see the vertebral disc bulge into the vertebral body called Schmorl's node, seen on the right here. So the more conservative treatment options are the first that are looked for in a patient with Scheuermann's kyphosis. So those that have a curve less than 60 degrees and that are asymptomatic will typically be observed or started on stretching and physical therapy regimens such as the Schroth physical therapy. As their kyphosis increases to about between 60 and 80 degrees, especially in those that are skeletally immature and have room to grow, bracing is a good option for them. This paper by Weiss et al. Has shown that Jewett-type extension orthosis seen on the left can correct the kyphosis by about 15 degrees. This is compared to this other paper by Atemedifar et al. That looks at the older and more clunky Milwaukee brace that does have a more significant correction up to 25 degrees. However, regardless of the amount of correction that these bracing options can have, the most important effect of bracing is that it stops the progression in about 98% of cases of Scheuermann's kyphosis. For those patients that continue to progress in their kyphosis to above 80 degrees, those that continue to have more significant back pain, any neurologic deficits, all coupled with the patient's clinical presentation and their own aesthetic concerns about their appearance secondary to the kyphosis, surgical management can be looked at for these patients. The most commonly performed procedure for these patients is a posterior spinal fusion with or without an osteotomy. This systematic review by Hook et al. Looking at the older anterior release plus posterior fusion compared to just a posterior fusion alone, found that the posterior fusion actually had better correction of the kyphosis and had equivalent outcomes and complication rates as the anterior plus posterior approach. So the posterior approach is the preferred method right now. An osteotomy can be performed to address even more of the kyphosis. So in our patient, we had performed a Ponte osteotomy, which essentially resects the spinous processes, the facets and the ligamentum flavum of the apex of the curve, the steepest portion. And on the right, you can see essentially the spine is released so you can have some more of that extension. Depending on the severity of the correction that you want to correct, the severity of the kyphosis that you want to correct, you can also perform other types of osteotomy, such as a Smith-Peterson osteotomy, pedicle subtraction osteotomy, or vertebral column resection. So, in conclusion, a patient with Scheuermann's kyphosis will likely be a growing male with a relatively rigid thoracic kyphosis. Radiographically, they'll present with 5 degrees of anterior wedging in at least 3 consecutive vertebral bodies, with or without end plate deformities, depending on the severity. Bracing is very effective for these patients in stopping the progression and even correcting the kyphosis. And finally, in those that don't respond to conservative management, that experience significant pain or other neurologic deficits, surgical options such as posterior spinal fusion with or without osteotomy can be performed. Thank you for your attention, and I'll take any questions.
Aneesh, is physical therapy prescribed for treatment of pain that this patient was having, or is it thought that might slow the progression of the curve, or both?
So the physical therapy was prescribed before the patient was experiencing pain when they were having the kyphosis. It is shown in most patients that experience kyphosis or scoliosis to help kind of address their curve and can help minimize the progression. It is also continued for after when he was experiencing pain, but mainly for the curve initially.
Surprising, because I'm sure the chiropractors would like to know that too, since they think they can affect the progression of scoliosis with their manipulations on a regular basis.
All right.
Nice job.
Thank you very much.
Hi, good morning. My name is Tiffany Smith. I'm one of the 4th-year medical students on the orthopedic surgery rotation. And this morning I'll be presenting on the discoid meniscus management and outcomes in pediatric patients. So to begin with my objectives for today, I will start by presenting a case of discoid meniscus in a pediatric patient. I'll then move on to review the physical examination and imaging findings associated with the discoid meniscus. I'll discuss some background in epidemiology, as well as the classification system currently utilized for the discoid meniscus. And finally, I'll analyze the existing literature on the treatment of the discoid meniscus in pediatric patients. So to begin with the case, we had an 8-year-old male present with a chief complaint of left knee pain. He reported about 4 to 5 months of a history of persistent left knee pain following a fall at the park. During that time period, he reported locking, clicking, and popping with ambulation. And he was ultimately seen by his pediatrician for his symptoms, who referred him to see a pediatric orthopedic surgeon for his management. He has no past medical history, no past surgical history. He is not on any medications, and he had no relevant family medical history. So in terms of the physical examination, this patient's left knee examination included an effusion of his left knee. He was tender to palpation of the lateral joint line, and on range of motion, he did have active clunking of the left knee moving from flexion to extension. In terms of his provocative testing, he was negative for a McMurray's, an anterior and posterior drawer. He was negative for a Lockman's and was stable to varus and valgus stress at 0 and 30 degrees. He was found to be distally neurovascularly intact and he had no gait abnormalities. So this patient was actually seen by a pediatric orthopedist before coming here, and that pediatric orthopedist ordered MRI imaging for this patient. And so when the patient came in to see us, he already had this imaging completed. So here we have his T2 weighted sagittal of his left knee. And here I have two still images, a coronal as well as a sagittal. On the coronal, you can see quite clearly both the lateral and medial meniscus. You can see that the lateral meniscus is much thicker in appearance than the medial meniscus, as well as it's taking up a much more significant portion of the lateral compartment than the medial meniscus is taking up. In terms of looking at the sagittal in this patient, you can see a hyperintensity pretty clearly representing a tear in the meniscal body, as well as a flipping of the posterior portion of this lateral meniscus. So in terms of the general assessment of this patient based on his history, physical examination, and imaging, he was ultimately diagnosed with a left lateral discoid meniscus with a complex intrasubstance tear. And the plan for him was to undergo left knee arthroscopy and partial meniscectomy with saucerization of the lateral discoid meniscus. So to provide some background in epidemiology, the discoid meniscus is pretty much a hypertrophic version of a normal meniscus, as well as oftentimes presents as disc-shaped. In terms of the histology of the discoid meniscus, it presents with decreased disorganized and degenerative collagen fibers. I included here a picture from a study that looks specifically at discoid meniscus tissue samples. And here you can see on Mason trichome staining that the collagen in this discoid meniscus tissue sample is the collagen is quite sparse, and you can see that there's no real organization. It's far decreased from what you'd expect for a normal meniscus, and it's one of the reasons why discoid meniscuses are said to be more susceptible to tearing. In most individuals who present with discoid meniscus, if they have an incidental finding, they can often be asymptomatic, and the oftentimes incident that causes symptoms is oftentimes a tear or instability of the meniscus. In terms of the general incidence of discoid meniscus, studies have shown that the incidence is anywhere from 3 to 5% in the US and gets as high as 13% in Japan. There has been evidence that shows that discoid meniscus has a higher incidence in Asian countries, and Japan is one of the countries on the forefront of doing research in this area. And so looking at their data and seeing that their incidence gets as high as 13% possibly points to a genetic component or familial cultural associations with the discoid meniscus. However, in terms of general understanding of why the discoid meniscus develops, it's currently unknown. There have been theories that postulate that during fetal development, there is failure of apoptosis of the central portion of the meniscus. However, none of those studies have been able to be substantiated from animal models. In terms of looking at how the discoid meniscus presents, it presents bilaterally in about 20 to 25% of patients, and it is much more significantly found laterally than medial. Lateral discoid meniscus is seen in over 90% of patients that present with discoid meniscus, and seeing a medial discoid meniscus is actually quite rare. So in terms of the classification of discoid meniscus, back in the late 1960s, Watanabe came up with a classification system that focused on both stability as well as discoid meniscus shape. So type 1 and type 2 discoid meniscuses are considered stable meniscuses and differ in their discoid shape. And so here you can see in the type 1 discoid meniscus, the discoid meniscus covers the entire tibial plate. And in these images, you can see that they are lateral, representing the most frequent presentation. And so in the type 1, you see that the discoid meniscus is representing the entire tibial surface in comparison to the type 2, where you see that less than 80% of the tibial surface is actually covered by the discoid meniscus. These are in contrast to the type 3 discoid meniscus, which is characterized by its instability, and that is due to absence of posterior attachments. The coronary ligaments that attach the meniscus to the tibia are not in place in these meniscuses, and rather only the Risberg ligament connecting the meniscus to the femur is intact. And so here you can see that the type 3 is named the Risberg variant. So in terms of discoid meniscus treatment, there are really two avenues one can take. There's the non-operative management and the operative management. For non-operative management, the indication is usually an asymptomatic discoid meniscus without tears, and that's usually an incidental finding. If a patient is getting worked up or imaged for a different issue and they're found to have a discoid meniscus at that time, but they're asymptomatic, the treatment at that time is observation, and that's been shown to be the best treatment method. In terms of patients who present with pain and mechanical symptoms, such as the patient I presented earlier, or those with a meniscal tear or meniscal detachment, the current treatment method that is recommended is partial meniscectomy and saucerization. And when I say saucerization, that's pretty much a debridement of the meniscal tissue to try to achieve a more anatomic or normal looking meniscus. And then for those who do present with instability, repairing the meniscus is warranted. So in order to get a better understanding of the treatment of the symptomatic discoid meniscuses in children as well as outcomes, I was able to find this paper in the Journal of Pediatric Orthopedics. It included 470 cases of discoid meniscus. It was a single institution study done out of Boston Children's, and it included all children who had discoid meniscus seen from 1991 to 2016, who presented with a lateral discoid meniscus, had no past medical history. So in terms of the general cohort characteristics, there were 401 patients included in the study. 69 of them had bilateral discoid meniscus involvement. So they had a total of 470 knees to use in their analysis. 82% of patients that were included in the study and had symptomatic discoid meniscus ultimately were managed surgically with saucerization and then repair if they had instability. And in these patients who underwent operative treatment, 63% were found to have tears intraoperatively. Out of those patients, 17% ended up having to undergo reoperation. And when looking at the reason or the intraoperative findings for those patients who underwent reoperation, a re-tear was found in 94% of those patients. In terms of non-operative treatment, 18% of the knees included in this analysis were ultimately or were initially managed non-operatively. However, about 39% failed that non-operative management, meaning they initially were slotted to be treated non-operatively, but eventually switched over to surgical management. And the median time period from switching over to non-operative management to undergoing operative treatment was about 7.9 months. In terms of reviewing some of the limitations of this study, one important factor was that this was a single institution study. Although they had a decent number of patients that they included over their time period, a generally larger study that included multi-institutions would be preferred. In addition, this study was a retrospective case series, and the retrospective data was not controlled for. And so in terms of general physical exams, pre-op, intraoperative decisions and reporting, as well as post-op follow-up, was not controlled for. And so looking forward at future studies, including those kinds of controlling factors would be appropriate. So now looking at this patient that I presented earlier, surgical treatment, he underwent left lateral discoid meniscus, partial meniscectomy and saucerization. You can see here on our diagnostic scope, we were able to visualize the left medial meniscus. And so we have two pictures here where you can compare the left medial meniscus to his left lateral discoid meniscus. You can see that his medial meniscus presents fairly normally. It, in comparison to the discoid meniscus, is much thinner. You can see here that the discoid meniscus is quite thick. It's taking up pretty much the entire viewing window. And here we have a probe in place that is testing the stability of the discoid meniscus. For this patient, his discoid meniscus was stable. And because it is taking up pretty much the entire lateral tibial surface, he was found to have a Watanabe type 1 discoid meniscus. So he was complete and stable. So after that, we were able to visualize his centrally located tear and proceeded with saucerization using right, straight, and back biters. And we were able to saucerize into a point of about 5 to 6 millimeter rim of meniscal tissue being left, which is preferred in these patients, especially young patients who have many years to continue using their lower extremities and to prevent degenerative changes over time. And so In terms of reviewing this patient's case and generally the literature that I was presenting in today's case, overall discoid meniscuses with symptomatic presentation are shown to be best treated operatively, as this patient was. In terms of non-operative treatment of symptomatic discoid meniscus, they show a much higher rate of failure and oftentimes ultimately end up being converted over to operative treatment. And then lastly, in terms of setting patient expectations, based on the collagen and histology that I mentioned earlier, even when undergoing saucerization and partial meniscectomy, oftentimes these patients still experience symptoms related to their discoid meniscus histology, which puts them at an increased risk for tear. And so oftentimes they experience re-tear and will have return of symptoms. And so making sure that patients are aware of this when deciding to undergo operative management and that they know and have these expectations is important. So thank you.
So for a discoid meniscus, you saucerized it and turned it into a normal looking meniscus. Do you think it functions the same as a normal lateral meniscus?
So I do believe it functions the same as a normal lateral meniscus, although the histology of that meniscus is different and it is at an increased rate for tear. I think in terms of thinking about dissipating stress between the tibia and the femur, I think that discoid meniscus probably in part does have a bit of less ability to handle stress than a regular meniscus, but for the most part, there are patients who are able to remain asymptomatic with those meniscuses. So I think although they may have a degree of less function than a normal meniscus, I do think for the most part, they are able to function fairly similarly.
Yeah, I think they function similarly because you've gotten rid of their mechanical symptoms. But what we don't know is what's the long-term outcome of the surgical treatment of, I mean, I've never seen a study like a 20 or 30-year follow-up on discoid lateral meniscus, treatment. So you may be getting rid of their symptoms, but they may still be predisposed to lateral compartment arthrosis later in life. And I doubt with the difficulty of long-term follow-up in patients, we'll probably never know the answer. So.
Yes.
Interesting thought though, because the collagen organization is poor. So the likelihood that meniscus is transmitting hoop stresses the same way a normal meniscus does is not particularly high, but it seems to work at least for a while.
Yeah, even in this study that looked over a 25-year period, based on it being a retrospective study that didn't include specific long-term follow-up parameters, it is interesting that there are no real studies out there that have shown long-term follow-up to really, especially in pediatric patients where that long-term follow-up is important to kind of understand how they progress in terms of possible later degenerative changes.
Good morning, everyone. My name is Dane Pizzo. I'm a fourth-year medical student at Robert Wood Johnson, and today I'm going to be talking to you about the presentation and treatment of cervical radiculopathy. Just for a brief overview of what we're going to speak about today, I'm going to start with a patient case presentation, as well as move on to some of the treatment options available for cervical radiculopathy, and finish with a brief literature review on the topic, as well as a summary. So patient JD is a left-hand dominant 42-year-old female who is presenting with 1 month of left arm pain. Prior to arrival in our office, she was seen by urgent care clinic and her primary care physician for this left arm pain. At that time, a cervical x-ray was performed, which did show some mild arthritic changes. Her primary care physician ended up prescribing an anti-inflammatory as well as a muscle relaxant and a short dose or a short course of oral steroids. 1 month later, the patient presented to our office. At this time, we learned that her pain was gradual in onset without any inciting factors, and that the pain also radiated down her left arm into her left wrist and her forearm. She had no significant past medical history, and her surgical and family histories were non-contributory. On physical exam, we did note a decreased sensory distribution, the C6 and C7 nerve distributions, as well as a positive left-sided Sperling's test. On strength exam, she did have weakness in the triceps as well as the wrist extensors on the left side. More specifically, the triceps was noted to be 3 out of 5, and the wrist extensors were noted to be 4 out of 5. The remainder of the physical exam was largely within normal limits. More specifically, her gait was normal, straight line with heel to toe walking. She had normal posture, level shoulders, no scoliosis, and a normal thoracic spine convexity and lumbar curve. As far as her cervical spine goes, she had no paraspinal tenderness palpation, no muscle spasms, and normal muscular tone. She also had pain-free range of motion with about 45 degrees of rotation to each side. While in the office, we obtained x-rays of her cervical spine. Here we can see an AP and lateral view. And on these views, we can notice a straightening of the normal cervical lordosis, as well as mild disc degeneration at the C5, C6, and C6, C7 levels, consistent with mild arthritic changes. Our recommendation was to follow up with us once she received an MRI. We also prescribed a refill of her anti-inflammatory and her muscle relaxant, and prescribed an additional dose of gabapentin at bedtime and a 6-week course of physical therapy. The patient did follow up with us once she received her MRI, which was about 3 weeks later. On the MRI here, we have a sagittal view as well as a transverse view. On the sagittal view, we can see a C6, C7 left paracentral disc protrusion. And if we trace this over onto the transverse view, we can see that this disc does protrude into the nerve space and impinge upon the C7 nerve root. A brief overview of the anatomy of the cervical spinal cord. Consistent with this patient's presentation, we do have a disc herniation at the C6, C7 level. I'm not sure if you can see my cursor on the screen. I don't think so, but her disc did protrude posteriorly at the C6 to C7 level, and her physical exam findings were consistent with this diagnosis, as well as her loss of sensory sensation in the C6 and C7 dermatomal distributions. So with her physical exam findings, as well as MRI findings, we're able to make the diagnosis of radiculopathy secondary to a C6, C7 cervical disc displacement. For this diagnosis, we typically use this treatment algorithm, starting with conservative therapy, moving to injections, and finally surgery as a last option. As far as conservative management goes, it typically consists of oral analgesics, corticosteroids, physical therapy, and just basic avoidance of provocative activities. At this point, the patient had only been to physical therapy a handful of times and wanted to opt for conservative therapy. So we allowed her to continue physical therapy and scheduled a follow-up in 6 weeks. She also continued use of her muscle relaxant as well as anti-inflammatories. 4 weeks later, the patient presented back to our office with minimal to no symptom improvement, and treatment options were once again discussed with the patient, and she opted to pursue definitive surgical management. At this time, a total disc replacement was performed. So these are the post-operative images from her total disc replacement. We can see successfully placed disc at the C6, C7 level on both the lateral and AP views. Just a brief discussion of the two surgical management options available for cervical radiculopathy. The first of which is cervical disc replacement, which is what we performed on our patient. As you can see, it's a small device that is placed in between the vertebral bodies that acts as a cervical disc. And another option is the anterior cervical discectomy with fusion. It is similar in that the disc is still removed, except this time the vertebral bodies are fused with plates and screws. Moving forward, I wanted to discuss two papers in the literature that compare cervical disc replacement to ACDF, both at the single level and multiple levels. In 2018, Finley published a systematic review that consisted of 14 randomized controlled trials with just over 3,000 patients, and they compared cervical disc replacement to ACDF at the single level. Outcome measures that they looked at were neck disability index, visual analog scores of both arm and neck pain, 36 question surveys that focus on both physical and mental components, as well as other outcomes such as range of movement, secondary surgical procedures, and adjacent segment disease. They looked at both short-term and medium to long-term outcomes, and short-term was described as 2 years, where medium to long-term was described as 4 to 6 years, or 4 to 7, my apologies. And in the short-term, specifically 2 years, they found significant differences in range of motion, the need for a second surgical procedure, adjacent segment disease, and dysphagia. Following that up with the 4 to 7 year time period, they also found significant differences in the neck disability index, the physical component score of the short form survey, as well as patient satisfaction. I think it's important to note that all of these significant differences that they found were favoring total disc replacement over cervical disc fusion. And there were some limitations to the study. There was no blinding. They also did have a high rate of loss of follow-up in many of the randomized controlled trials, anywhere from 20 to 50%. And the mean patient age was 40 to 50 years old. So the next study, published in 2017, also compared disc replacement to ACDF, but in this study, they looked at multiple levels rather than a single level. Outcomes looked at here were included operative time, blood loss, neck disability index, as well as range of motion, adjacent segment disease, postoperative events, and dysphagia. In this study, they found significant differences when looking at the range of motion of the C-spine, as well as the range of motion at the operated levels, adjacent segment disease, adverse postoperative events, and dysphagia. Once again, all of these outcomes were in favor of total disc replacement over cervical disc fusion. But once again, they did have limitations. The mean age was also 40 to 50 years old. Throughout these 7 studies, there was highly variable follow-up times. There was no blinding, and they also provided no explanation for what they termed as adverse postoperative events. So in conclusion, through both of these studies and pulling this data together, we can come to say that there's several outcome measures that total disc replacement is superior to anterior cervical discectomy with fusion. It's important to note that ACDF was not found to be superior to disc replacement at any time point across any of the outcome measures of these studies. And because of this, it kind of led me to the question of, if total disc replacement is superior to ACDF in all of these outcome measures, then why do we still perform ACDF so frequently? And the answer to this is multifaceted. So there's multiple clinical indications for ACDF compared to total disc replacement. These include things like node malignancy, osteoporotic bone, infection, just to name a few. And in addition to that, we have a lot more data on ACDF. It's been around for a much longer amount of time. It's been shown to be an effective treatment mechanism. It has fewer unknown risks. More surgeons are trained on it, and it's also more widely covered by insurance since it's been around for so much longer. This being said, that's not to say that total disc replacement isn't superior, but it hasn't been around for long enough for us to have this extra long-term data to know if it is successful in the long run. Thank you. These are my references. I take any questions that you guys have.
So when you're on your plain films, you saw loss of cervical lordosis. What does that mean? If they have that straight cervical spine.
Back to them. Yeah, so on the plain film we look on the left-hand side of the screen, we can see the lateral view. Normally cervical lordosis of this cervical spine sits at about 15 degrees in this patient. She has loss of that and straightening, so the vertebral bodies are more aligned with less lordosis.
Do you know why? Like what is that? What is that an indication of? Why doesn't she have her normal lordosis?
Maybe due to some degenerative disc changes at the C6 and C7 levels. She may also be compensating and holding her neck into more flexion could be causing that.
Right, so I mean, I've always been told it was muscle spasm. I don't know if that's really the case, but it's always kind of the generic answer.
Okay. Yeah. And interestingly enough, on physical exam, our patient didn't show any muscle spasm, but that was at, very limited time points. So that very well could be possible.
Nice job.
Thank you.
Right. How you guys doing? My name's John Flacco. I'm also a fourth-year medical student in RWJ. And today I'm going to be talking about posterior malleolar fractures and the discussion around when to perform fixation. Real quickly, some of my objectives for this presentation. First, I'm going to present a case study containing a posterior malleolar fracture. Then I'm going to quickly review the ankle anatomy, quickly review the classification of ankle fractures, and then discuss indications for the posterior malleolar fracture and subsequent fixation. So I came across this patient on one of my first call shifts. She's a 52-year-old female, presented status post-fall going upstairs with a closed right SCR4 44B trimalleolar fracture and dislocation. Her review of systems was negative. She didn't hit her head, no loss of consciousness, no other extremity pain, no numbness or tingling. Past medical history just for depression on sertraline, and otherwise the rest of her history was non-contributory. When on her physical exam, vitals were within normal limits, BMI of 27.98, so she was overweight but not obese. On inspection of the joint, she had obvious ankle deformity. Skin was intact with ecchymosis and swelling present. On palpation, she had tenderness and palpation over the ankle. She was non-tender over the knee, hip, and foot. Otherwise, she was neurovascularly intact and motor intact. So we have her imaging pre-reduction here, and you can see the oblique fibular fracture at the level of the syndesmosis. You can see the medial malleolar fracture. It's pretty tough to see the posterior malleolar fracture, and we'll see why in the CT next. But here you can also see a pretty obvious posterior dislocation of the talus relative to the tibia in the lateral view. So here's the CT scans looking at the fractures, and here's the axial cuts. You got the lateral there. You see the small posterior mal fracture pops up for a second. Then you also can see the medial mal. Let's look at the. There's one. There's the medial mal, lateral mal, and then quickly the posterior mal. All right. So this patient was taken in for open reduction internal fixation. I include these intra-op fluoroscopies to really stress in this top, I guess, left corner of the screen. You can see the cotton stress test being done, which is basically through the lateral incision, you're putting force on the fibula, lateral force on the fibula, and you're looking for interosseous widening or also medial space widening with this, and that would be significant for joint instability. In this case specifically, you can see that the posterior mal was not fixated, and I commented on the small size of the posterior mal fracture because, as we'll talk about later in the indications, that comes into play, and also this cotton stress test will come into play in terms of joint stability for fixation of the posterior mal. But instead, for this for this surgery. Here's the post-fixation images. They went with 2 bicortical screws on the medial side and a distal fibular locking plate on the lateral side, and they got sufficient reduction in joint stability out of this. So there's no need for fixation of the posterior malleus at this time. Pretty underwhelming for my presentation, but if we have time at the end, also show another case that I wasn't a part of at St. Peter's, but that did have fixation of the posterior malleus. So just quickly go over the ankle joint. You have the bony anatomy, which is made up of the superior dome of the talus and the distal component of the tibia, the plafond, and the distal component of the fibula. This forms a saddle-shaped mortise joint. There is some intrinsic stability with this bony anatomy. You have the concavity in the AP direction of the tibia and convexity in the lateral direction that matches the AP convexity of the talus and lateral concavity of the talus. You also have AP in the anterior portion of the tibia and talus, a wider, and it gets narrower as you go posterior. This creates kind of a wedge shape and also gives the joint stability in dorsiflexion. Now, when we get to the ligamentous anatomy, there's 3 important structures of the ankle in terms of ligamentous anatomy. You have on the medial side, the medial collateral ligament with a deltoid ligament. This is the version. There's 2 different portions of this deltoid ligament. There's a superficial and deep portion. The deep portion is the primary medial stabilizer of the talus. Then when you look at the lateral side, you have your fibular collateral ligaments. These resist inversion. This includes the anterior talofibular ligament, which is the always tear first. And as medical students, we come across that a lot in board questions of what happens when your ankle's inverted and what tears. And then we get to the important for this discussion, the syndesmotic ligament complex, which is between the tibia and fibula. And this complex resists axial rotational translational forces. It's made up of 4 ligaments. You have your anterior inferior tib-fib ligament. You have your anterior osseous ligament, which is a continuation of your IO membrane. And you have your PITF, your posterior inferior tibulofibular ligament, which is the strongest of the syndesmotic ligaments and actually provides 42% of syndesmosis stability. This is important, especially when we discuss posterior malleolus fractures due to the fact that its origin is on the posterior tibia, that posterior malleolus fracture at the Volkmann fragment attachment, and also runs and goes to the lateral malleolus on the fibula. There's also the inferior transverse ligament as well, which is inferior to the PITF. So when we talk about ankle fracture classifications, we come across the Logie-Hansen classification. This is based on ankle position of force applied at time of injury. It's great because it gives you an idea of the structures that can be involved just by having one either supinated, pronated, external rotation versus abduction or adduction, and it can give you an idea of the severity, and it can give you an idea, get you ready to prepare what you might need to do for surgery. You also have the Aota Weber classification. This is based on location alone. 44, if you see the number 44, you know you're at the malleolus, and then A, B, or C represents if it's at the level of syndesmosis, above it or below it. Now, when we get into posterior malleolar fracture discussion, one of the things I really want to stress is that they are found in 40% of ankle fractures, but they're very rarely, 1 to 4% in the literature, found alone. This is important because when you're going to fix it, when you're discussing fixing a posterior malleolar fracture, you're doing it in relation to fixing of a lateral malleolar or medial malleolar fractures as well. And that becomes very important when we talk about syndesmotic instability, because there's different ways to stabilize syndesmosis. And that comes into play, especially with lateral malleolar fractures in congruence to a posterior malleolar fracture. So when you look in ortho bullets, what do you find for the posterior malleolar fracture indications? You come across as 25% of tibial joint surface value. You also come across articular step-off greater than 2 millimeters, and syndesmotic instability and posterior subluxation of the talus. For my discussion, I'm going to first talk about this 25% of tibial joint surface. In the literature, especially, there's a lot of cadaver studies, biomechanics studies showing that the larger the posterior malleolar fragment, the less favorable your outcomes for the patient. That's in joint stability, also in progression of degenerative changes at a quicker rate. And that 25% value is found because that's when the forces on the remaining tissue get significantly increased. And you also see this increased rate of degenerative changes. Now, when reading the literature, as I was, you kind of get into the weed of things, you see there's a lot of hedging when talking about the posterior malleolar fractures, because there just isn't a lot of great clinical data. And there's still a lot of arguments over even this 24%, 25% value. But one of the landmark papers that really solidified and kind of created a consensus on to make sure you do fix the posterior mal when you're greater than 25% of the articular surface is involved was this paper, which looked at long-term results of ankle fractures with posterior malleolar fragments. The strength of this paper really looked at the 13-year average follow-up, so you get an idea of degenerative changes in these fractures. And there's two groups. There's less than 25%, which they didn't fixate, and there's greater than 25%, which they did fixate, or at least 82% of the times did fixate when it was greater than 25%. And basically, they found at this 30-year average follow-up that the more dramatic fracture pattern of greater than 25% did just as well as the less dramatic fracture patterns that weren't fixated in clinical scoring, anatomic findings, and arthritis development. This has created a pretty strong consensus that if you're greater than 25%, in most institutions that I read about, if it's greater than 25%, you are going to fixate the posterior mal. How you fixate it is still discussed, but it's also then, now when you get into, and I stressed this earlier, the syndesmotic instability, and specifically with tri-mal fractures, and because posterior mal rarely happens and by itself, you start to talk about syndesmosis instability, and specifically for these fractures that are less than 25% of the articular joint. Is there a benefit to fixate the posterior mal when it's less than 25% of the articular surface is involved? This paper, and before this paper, there was also cadaver papers that basically combine two schools of thought. So because the posterior mal fracture is associated with lateral malleolar fractures and medial malleolar fractures a lot of the time, there's another syndesmotic stability can be addressed with a syndesmotic screw through a lateral incision. This is the supine group, as you see in this paper. So you put the patient supine, you fix the medial mal, you fix the lateral mal, you do a cotton wool test, which assesses for syndesmotic stability. If you see widening at the medial space or in the interosseous space, you then put a syndesmotic screw. Now, you then continue to test for if the joint is stable by putting stress on the fibula, lateral stress on the fibula again. And if there's still instability, you fix the posterior mal fracture as well. But it's not always needed. And then you have the prone group, where you put the patient prone, you do a posterolateral approach, you directly look at Volkmann's area, you fix the posterior fragment directly. You can also approach the fibula from that approach and fix the lateral mal. And then this research, this study in particular, looked at syndesmotic instability of those two approaches and compared them. Specifically, it found that 72.8% of the supine group, so doing a syndesmotic screw, doing the lateral medial syndesmotic, did not require syndesmotic fixation, versus when you did a direct prone group posterior approach, posterior fragment fixation, 97.9% of those patients did not require syndesmotic screw. And now another big takeaway from this is that even when the supine patients who received the syndesmotic screw, a quarter of those patients went on to have supplemental posterior malleolar fixation anyways. So you had to fix, in a quarter of those patients, you had to do posterior malleolar fixation with the syndesmotic screw also, where 97.9 of the posterior direct approach with posterior fixation did not require syndesmotic screw at all. So this brings me to my conclusions, which basically we talked about the indications for fixation, the reduction in the articular surface when you have a fragment greater than 25%. Then there's joint instability. Again, we saw better outcomes with fixation of fragments greater than 25% and an increase in syndesmosis stability when you have direct posterior mal fixation. Further topics, when you get into the weeds of this a lot more, and there's great studies on this, there's like indirect versus direct fixation of the posterior fragment using an A to P lag screw indirectly when you have a lateral incision versus a direct buttress plate when you do a posterior approach. There is a good study on that did show at least some indice, some trends toward better outcomes using the buttress plate directly on the posterior fragment. Here's this case that was at St. Peter's. It's a more dramatic posterior mal fracture, just to give you, because it was a little underwhelming to not have the fixation, but here you can check it out. I wasn't involved in this case, but you can see that the fracture pattern and it's much greater than 25%. And they did a posterolateral approach with the patient in a prone position with direct buttressing of the Volkmann's fragment. Thank you. I want to thank the residents for helping me, allow me to pick their brains and kind of centering me and allowing me to get a better understanding. And are there any questions at this time?
What do you think on that last case that you showed? If they hadn't gone posteriorly and fixed the posterior mal, would that have required a syndesmosis screw?
If they did the lateral approach and they there would have been instability because it was greater than 25%. They would have had to do a syndesmotic screw from the protocols that I saw. And honestly, even if they did a syndesmotic screw, the size of that fracture, the PITFL would probably still be avulsed. You'd have to end up doing some type of fixation of the posterior mal as well. They usually, because the patient's in the supine position, they attack anteriorly and do a lag screw, at least what I've seen in the literature. So yeah, I'd imagine you'd have a syndesmotic screw on that one. That was a pretty large fracture of the posterior mal. All right.
Nice job.
Thank you.
Gonna leave my mask on. I'm gonna be coughing all over the podium and my last day of required mask wearing for CDC guidelines. So I'm Bob Delcortivo. I'm a visiting student from Rutgers in Newark. I'm going to be talking about periprosthetic fracture using a case I saw during the beginning of the rotation help guide the discussion. The objectives to review the epidemiology and classification of periprosthetic fractures, understand how classification impacts clinical management, and to evaluate the literature. Some background on the patient. 92-year-old female. She had a prior history of a left total hip, status post revision following a periprosthetic fracture back in 2017. Also a left total knee. She presented after falling onto her left side while using a walker, feeling immediate pain and inability to bear weight. Past medical was significant for AFib with a pacemaker, prior breast cancer and CKD. Past surgical history, as I mentioned, left total knee and a left total hip status post revision already. Here's the imaging. You can see on the AP, it's a spiral type fracture in the distal third of the left femur between the hip prosthesis and the knee prosthesis. I'll get into the classification of this in a moment. So some brief epidemiology. This is based on a study in JOT out of 2011 for fractures around the total hip. So I'll talk about both fractures around the total hip and a total knee since she had both. So fractures around the total hip incidence ranges anywhere from 0.1% to 18% in the literature. The upper end of this range is primarily due to revisions. There's a significantly higher rate of fracture for revision arthroplasties. It's most common after low energy trauma. Patient-based risk factors are increased age, female gender, and high BMI. Risk factors from a surgeon's perspective are underreaming of the acetabulum. So not only can you cause a femoral fracture, but also an intraoperative acetabular fracture as well. Rapid or forceful femoral preparation or implantation and using an uncemented construct increases your risk of fracture. For fractures around a total knee, incidence ranges anywhere from 0.3% to 30%. Again, the upper end of this range is higher for revisions. The femoral side is typically impacted more than the tibial side. Risk factors to the patient are osteoporosis and RA due to poor quality bone. Surgeon-based risk factors is femoral notching being violation of the anterior cortex while preparing the femur. So I'll go over classification systems, both for total hip periprosthetic fractures and total knee. I'll start with the hip. So typically use the Vancouver classification, a type A Vancouver. This fracture in the trochanteric region that's typically can be treated either non-operatively or operatively. The decision is this usually displacement of the greater troch. It's greater than 2 centimeters. You'll want to fix it usually with a claw plate to help pull that trochanter down and secure it. If it's less than 2 centimeters, it can be treated non-operatively. Here's an example. A type B1 is a fracture around the stem, but the stem remains well fixed in the bone. You want to fix this usually with either a lateral locking plate or a cerclage plate. Important to note that classifying this a B1 versus a B2 or B3, as I'll say in a second, B2 or B3 will have a loose stem. Can't always make this decision based on radiographs. Sometimes you need to stress it intraoperatively in order to make a final decision. So you have to go into the case prepared to fix either a B1 or a B2 or 3 if the fractures around the stem. So like I said, a B2 fracture around the stem is loose. The difference between a B2 and B3 is the quality of the proximal bone stock. So a B2 will have good proximal bone stock, a B3 will have poor proximal bone stock. Given that your prosthesis is loose, you'll need to revise this component, usually with a long prosthesis to span the fracture site, and use a cementless construct with a long, fully porous coated stem to help promote bony ingrowth and further secure the stem. And then you'll need to fix it as well with usually with a lateral locking plate. B3 is similar treatment to a B2, other than you have poor proximal bone stock, as you see in this example. The bone stock is pretty bad. What you'll need to do differently for these fractures is to kind of restore that proximal bone stock either through allograft or proximal femoral replacement. And then a type C is a fracture well distal to the tip of the stem. You can treat this as a distal femur fracture and treat it with ORF, again, a lateral locking plate. So those are the hip periprosthetic hip fractures. Now, periprosthetic knee fractures, the classification, SU classification, the type 1 SU is fracture proximal to the femoral component. I'll talk about treatment more extensively in a moment. Type 2 is a fracture that originates at the proximal end of the femoral component and extends proximally, as seen in this example. And then a type 3 is where the fracture extends down to the distal to the upper edge of the femoral component. So circling back to our patient, on the AP, it might be tempting to call this a Vancouver C, but if you look on the lateral, the fracture line extends up towards the distal aspect of the stem. So I could see an argument to classify this as a B1, but I'd be interested in people's opinions on whether you'd call this a B1 or a C. I'd probably lean towards a B1. And then for the SU classification, the fracture is proximal to the knee prosthesis, so I call it a SU type 1. So I already touched on management of the periprosthetic hip fracture, so I'll go into a little more into the weeds on the periprosthetic knee fractures. There's a bunch of different options you can use for these. Versus non-operative treatment, usually with a non-displaced fracture. You'll treat with a hinge knee brace or casting. It's reserved for non-ambulatory patients or those unsuitable for anesthesia, but those are significant risk for wound healing, poor wound healing. Unsurprisingly, the rates of non-union in this are pretty significant, ranging from 12 to 40%. So this is kind of like a last ditch effort if you don't have any other good options. Probably the most common is plate and screw fixation, typically use the lateral locking plate. The pros of this is that it's amenable use for in osteoporotic bone, given that you can use locking screws. You can span the length of the femur and reducing the chance of a stress riser. You can also consider using a dual plate construct if you're concerned about the stability of your fixation. Some of the cons of this compared to a retrograde nail, which I'll touch on in the next slide, there's a more extensile surgical approach. And the patients can immediately bear weight, which can be an issue for some patients who want to be highly functional. These outcomes down here from a JBJS review article, non-union rates are in the range of 5 to 13%. Malunion rates around 5%, deep infection rate around 5%, and the loss or impairment of ambulatory status in up to 30%. So there are pretty significant, these are not low numbers by any stretch of the imagination. So the complications rate can be, there's a good amount of morbidity associated with these fractures. Another option is intramedullary nail fixation. You usually go retrograde in order to have more control over the distal component. The pros of this are a more limited surgical exposure, minimal soft tissue stripping. So theoretically less infection risk. Easy placement of the nail and immediate weight bearing. So patients who have high functional demands, this might be a preferred option. The cons is so given that you have a femoral component of a knee prosthesis already there, it might force your starting port a little bit more posterior than you want it to be, or than is ideal. So that may risk fracture the anterior cortex if you're trying to push it back a little bit anterior, or it might cause you to malreduce the fracture and not really have an option to reduce it well. Then fractures that extend to the femoral implants, like a SU type 3, may result in more limited interlocking screw options because you have metal in the way of where you want to drive your screw. From the same JBJS review article, the infection rates have been shown to be lower than compared to conventional plating, but the union rate compared to locking plates been shown to be pretty similar. I'll pull out one article from that review article and talk about it in a little more detail later in the presentation. some of the new the new trend or new option that has been developed in recent years is combined IM nail and plate and screw fixation. If you have patients with highly osteoporotic bone or young patients with very high energy mechanisms that require additional stability and also want to weight bear more immediately, this can be an option. Some of the pros, like I said, increased stiffness of the construct if needed, and earlier return to weight bearing. The cons is that increased surgical time because you have to not only place a nail, but a plate as well, higher cost. And it's been relatively understudied, so the outcomes are relatively unknown. There was one case series published with only 9 patients. They did have 100% union rate by 20 weeks, but again, a really small sample size. So more research is needed for these. And then the last option is a distal femoral replacement. So the pros of this is that you're able to mobilize very early because you have a prosthesis in place. You don't have any need for bone healing. And you have immediate restoration of lower extremity alignment and stability. The cons is that it can be costly. You have a risk of failure with limited options for salvage. A lot of patients view the DFR as a salvage option. If you use that as your first line treatment, you kind of take away that option from yourself. And then during the procedure, you can have soft tissue compromise, which can result in increased rate of infection. For outcomes, the short and intermediate term outcome complication rate. So from the same JBJS article, they looked at periprosthetic fractures, aseptic loosening, extensor mechanism complications, and periprosthetic joint infections as a whole. In aggregate, the complication rate was 15 to 30%. So pretty high. This probably isn't a first line treatment, but again, more of a salvage type option. So pulling out one of the systematic reviews. So this was published in JOT back in 2014. It was included 44 studies with over 700 fractures. They included studies with 5 or more distal femoral fractures above a total knee. And they looked at those treated non-operatively with a conventional plate, a locked plate, or a retrograde nail. They excluded patients requiring revision arthroplasty. Outcomes they looked at were malunion, non-union, and another number of secondary surgical procedures. So that's this SSP. So with respect, I highlighted the significant findings. With respect to malunion, locking plates were superior to all other treatment modalities. Additionally, retrograde nail was superior to non-operative treatment. For non-unions, retrograde nail was superior to non-operative treatment. And with respect to secondary procedures, locking plate and retrograde nail were both superior to non-operative. So to kind of just summarize all this, it appears that non-operative treatment has the worst outcomes, which is unsurprising. Locking plates appear superior than other form of treatment, particularly as it relates to malunion, which makes sense because when you're using a plate, you can probably achieve a better reduction than a nail. But if you look at rates of non-union, although the result is insignificant, there was a trend toward significance where the nail had lower rates of non-union than locking plates. So comparing locking plates against retrograde nail, still up for debate. I think more studies need to be done. These were all retrospective studies, level 4. So I think we need randomized controlled trials to really tease this out a little bit more. So circling all that back to our patient, looking at some of the options, you can't really put a nail given that she already had a prosthesis in place, a long stem revision prosthesis. So there's no room for a nail to go. So you can't use a nail. You can't use a nail or plate combination. DFR also not really an option because the stem of the DFR would likely, there'd be no room. Again, the hip prosthesis is in the way. Non-operative treatment, again, is not really ideal, especially for a patient who is ambulating with a walker prior to surgery. So some degree of functional status. So really the main option here was to use a lateral locking plate, which we did with a couple lag screws. And we also added an additional cerclage wire. You can see 3 in the picture, but 2 of them are from the prior surgery. We added 1 for additional stability proximally. So happy to answer any questions.
What's the weight bearing status on that patient?
I believe she's non-weight bearing, right?
For how long do you think that is?
Probably in order for the fracture to heal, so probably 6 to 8 weeks at least.
That's the challenge, is trying to get something where they can,
Sure.
you know, because they're not usually not elderly people with not great strength, and asking them to be non-weight bearing for an extended period of time is a challenge. But I think, like you said, you reviewed all the options and that's your best option, probably.
Potentially the only option. I was, yeah. So we use point of reduction clamps to put it into place. Yeah, it was open.
What's the best screw placement for when you have a large construct like that? Where do you want to put your screws?
Sorry, can you repeat the question?
What's the best screw placement when you have a long plate like that? Where's the best place to put the screws?
So you want fixation both proximally and distally. You should have space to go around this total knee. So you want locking plates distally or locking screws distally because you have metaphyseal bones going to be poor quality. So you're going to want to secure down there. And then approximately you have the stem in the way. So you're going to have to go probably unicortical. I don't think you can get around the stem. So you're going to want some both proximally and distally.
I think it makes it a big challenge when you have, implanted hardware to get around those things, but the locking screws really make a big difference. And, in order to not make it too stiff at the fracture site, you want to be careful where you put your screws so you don't create a situation where the bone will have trouble healing.
Sure. Sorry, there's another question.
Yeah,
in the room.
just earlier you mentioned for the treatment of Vancouver B2, you'd said that there was use of a fully coated porous stem.
Sure.
Do you know another option for that is more common?
Another option for that.
Type of stem that's commonly used, or a stem design?
I don't. The one I'm most familiar with is just to use a fully coated porous stem, allow bony ingrowth and help the fracture heal biologically. But I'm happy to hear if there's a more common option.
Yeah, we're gonna have a nice lecture about it later, but it's
Perfect.
no, it's more common to use modular stems.
Okay,
Sort of Wagner tapered stems that engage the diaphysis.
gotcha.
So you're not relying on metaphyseal bone. The stems that you're referring to are the ones that would use the traditional fully coated, like AML style stem.
Okay.
Where you use the concept of scratch fit, and those are sometimes very difficult to instrument.
Okay.
With periprosthetic.
Gotcha.
And then the second question I had was, you had mentioned with distal femoral replacements, when the bone is shattered and you're trying to assess your rotation for placement, do you know what the typical landmark is that you would use?
To assess rotation intraoperatively. So I think you can
You're
look.
trying to place the distal femur if you don't really have a trochlea and the normal anatomy that you might use, or epicondyles.
I'm not 100% sure. I know if you're placing a femoral nail, you can go up to the hip and look at the profile of the lesser troch and help that guide your rotation. I'm not sure if there's something different for DFR.
Any of the residents help them out?
Sorry, delineate aspera. Okay, gotcha. Cool.
Reason that's important is one of the more common complications of the DFR is, even if it doesn't get infected and it does well, is if you malrotate it, these patients will have patellofemoral problems with the patella dislocating. So,
Thank you. Any other questions? Thank you.